Well, welcome to this presentation about addressing increasing rates of type 2 diabetes in a First Nation community in my region. The closest First Peoples to Prince Edward County, Ontario are the Mohawks of the Bay of Quinte. These First Peoples, numbering about 2,500, reside on the Tyendinaga Mohawk territory, a 73 square kilometer tract of land that backs onto the Bay of Quinte on the north shore of Lake Ontario about 10 kilometers east of Belleville in Hastings County. The Mohawk Nation selected their current territory in the late 18th century in a deal with the British Crown for their allegiance and service to the Crown during the American Revolution. Although the land was unsettled, it was known to the Six Nations people because it was part of a vast northern territory controlled by the Iroquois Confederacy prior to the Royal Proclamation of 1763. Prior to the 1940s, diabetes prevalence among First Nations communities was extremely low. Today, because of sociocultural, biological, environmental, and lifestyle changes, rates of diabetes among First Nations communities have swelled to 3 to 5 times the rates among the general population. As is typically the case, prevalence of diabetes increases with age. But among First Nations community, it is being diagnosed at increasingly younger ages, and currently type 2 diabetes is much more frequent among First Nations youth and children than in the general population counterparts. In addition to much higher rates of prevalence of diabetes than the general population, higher rates of comorbidities, complications, and mortality from diabetes are also observed in First Nations adults living on reserve. Adverse health consequences as a result of diabetes, which 89% of First Nations adults with diabetes living on reserve reported one or more of in 2002 and 2003, include problems feeling hands and feet, vision loss, heart problems, and impaired kidney function. While diagnosing and treating complications that arise from diabetes add considerably to costs of providing health services to First Nations communities, it is addressing the disproportionate rate and severity with which diabetes affects First Nations individuals that prompts this project. In researching the challenge of increasing rates of type 2 diabetes among First Nations people in Canada, I found an abundance of publications relating to the issue. The Government of Canada has published Diabetes in Canada, Facts and Figures from a Public Health Perspective, which includes a chapter dedicated to the issue as it pertains to First Nations, Inuit and Métis. Another excellent source of facts about diabetes and other socioeconomic and health indicators that pertain to First Nations people is the National Report of the First Nations Regional Health Survey. Currently in its third phase, the Regional Health Survey is created, conducted, and carried out by First Nations people for First Nations people. The Aboriginal Diabetes Initiative is a federally funded program aimed at reducing the incidence of diabetes amongst First Nations, Inuit, and Métis people in Canada. It has been criticized for its lack of success, however, and for its framing the diabetes problem as primarily stemming from First Nations people's poor health, decision-making, and lifestyle choices. Brooks et al. Argue rather that federal policies should be realigned to better address the social determinants of health, namely colonialism, education systems, and access to health care. Observing that current education curricula ignore Aboriginal content and learning styles, one policy recommendation that Brooks et al. Make is to encourage First Nations to control their education. The researchers note that by improving the level of education attainment within First Nations communities, there is evidence that access to health services will improve, and subsequently health too. Interventions into education systems appropriate to the needs and priorities of the community were one means by which the Sandy Lake First Nation have had success addressing the high rates of type 2 diabetes it was experiencing. Since the founding of the Sandy Lake Health and Diabetes Program in 1991, the community has instituted many interventions and activities. For example, a program to increase the availability and knowledge of healthy food options, a home visit program for prevention and management of diabetes, a local radio show, a summer camp, a school diabetes curriculum for grades 3 and 4, and a walking trail, pictured, and various events to encourage physical activity. Community ownership of the Sandy Lake Health and Diabetes Program has ensured that programs and strategies are culturally appropriate and that they evolved according to their uptake and availability of resources. One of the most successful aspects of the Sandy Lake Health and Diabetes Program has been the school-based program that, despite experiencing an end to its funding in 2007, has been continued by community members. Aspects of the Sandy Lake Health and Diabetes Program have been piloted and studied by other First Nations. For example, the Ziwapenewin at FinalProject Teaching to Prevent Diabetes program. This program included school, store, and community components aimed at improving dietary choices and physical activity by increasing knowledge, self-efficacy, and attitudes about healthier behaviors, as well as improving availability of opportunities to perform them. Research has shown significant increases in frequencies of health food acquisition resulted. Another research finding that I'll be discussing later is the example of peer mentoring in the Garden Hill First Nations. While the geographical context of the Mohawks of the Bay of Quinte is quite different to the Sandy Lake First Nation, a series of community-based interventions similar to those implemented by the Sandy Lake Health and Diabetes Program, aimed at improving dietary choices and increasing physical activity, have the potential to effectively address the rising rates of type 2 diabetes within the Mohawk community. As with the Sandy Lake Health and Diabetes Program, the process of implementing community-based activities and strategies should begin by gathering community perspectives on diabetes. The qualitative data generated from this step should be used to inform the development and focus of community-based intervention programs. In addition, a survey of current diabetes programs and perspectives of individuals involved within these programs should be conducted. Currently, the Mohawks of the Bay of Quinte run a program on diabetes education that employs a diabetes nurse educator and a registered dietitian. I think that the effectiveness of the current program should be assessed by consulting with the individuals that work within the service and those that receive the service. Areas of strength and areas of opportunity should be determined and discussed. I would begin by contacting Sherry Brandt, the diabetes educator at the Community Wellbeing Center in the Tyendinaga Territory, to open a dialogue about how to improve the education systems and current health services. As evidenced by the Sandy Lake Health and Diabetes Program and the Teaching for Prevention of Diabetes Program, community-based strategies can reach more people and make more lasting environmental changes to support individual behavior than can individually targeted interventions. Hence, I argue not for one particular strategy or program to address the challenge of type 2 diabetes, but for a process that recruits and involves stakeholders of the Mohawks of the Bay of Quinte in coming together and accessing resources by which the current education systems and health services can be improved according to the community's desire and vision. I think an important aspect of this process will be to provide examples of how other First Nations communities have had success. One such example that used community-based principles similar to the examples from the Sandy Lake Health and Diabetes Program was an experimental trial in the Garden Hill First Nation. This intervention proved effective in reducing weight gain and increasing knowledge of healthy living among grade 4 participants. It was centered around an after-school, peer-led program aimed at teaching 4th grade students healthy living behaviors. Also, it followed the principles of participatory action research and involved years of formative work and relationship building prior to implementing pilot peer mentoring program. I suggest that this educational program could be adapted to suit the Mohawks of the Bay of Quinnie's needs and goals. As demonstrated by the Sandy Lake Health and Diabetes Program, the long-term success of such a program will be dependent upon the community's ownership, and hence community stakeholders should be involved in any program from planning through to implementation and assessment. Also, any program must respect the rights of First Nation peoples to self-determination. The examples from Sandy Lake and from the Teaching for Prevention of Diabetes program should be discussed and shared. Perhaps an after-school peer mentoring program would be effective and appropriate to the needs of the Mohawks of the Bay of Quinte. Thank you for listening, and these are some references that I consulted in this presentation.